Uh, yeah, yeah, yeah,
Guys. So this is Dr. Bo Beard. If you guys can't hear it, sorry, you guys can like put it on your phone or something maybe. But he is one of the founding members of R2P. He's going to be coming here to Costa Mesa sometime soon around May. Okay, he is a very, very, very smart man. And definitely someone that you should familiarize yourself with. I'm sure some of you guys have seen some of his like YouTube from the farm. We've tried to play it a lot. A lot of DNS stuff gets thrown out there. So I'm gonna shut up so he can kind of go a little bit more into it.
Well, thanks, Kat, for having me on today and introing me. And hello to everybody there. I can't see anybody, but that's okay. I'm looking at a wall. Yeah, I just wanted to do a very quick little presentation of just the basics of what Art of Assessment is, since I'm bringing that course to Costa Mesa, which is Memorial Day, which I realize is not ideal to do a class on a holiday, but that's how it's working out. Because there's multiple of those things you just saw. Those are kids, by the way. So time's limited, but quick intro to what the course is, some expectations, but really I want to open it up to questions. And if the questions aren't about Art of Assessment, I'll answer questions because this is your time too. So I'm going to go ahead and share my screen so I can just go over some stuff and you can ask questions. We're going through this. So the first thing I want to kind of go over is, well, why design a course other than like I like to teach? I could teach about a lot of stuff. Why is it go into this assessment realm? I think we really are challenged nowadays. I mean, we have been forever as physicians, and I'm saying all physicians, not just chiropractors, PTs, MDs, whatever, of the challenge of what's actually going on with the patient, right? So if we look at, like the show House or the best diagnosticians in the world or something, like there's something about the best in the world. Even the people that we think are the best at treating, they're actually the best diagnosticians because it's easier to treat when you actually know what you're treating. And I think that is a big, I hate to say problem because I don't want it to sound negative, but I think it's a big issue in our field that we take techniques and we take beliefs, which gets scary, and we take just things that we were surrounded by, within the environment of school and who we familiarized ourselves with. And that's what we do, right? That's how we intervene. And if we know anything in particular about conservative musculoskeletal medicine, it's that you can have an impact, a change, make something different by doing literally anything. So then you have to ask yourself, well, the first thing we want to do is make a positive change, right? And we know statistically speaking, that's not what happens, right? It's more often than not, we make a negative change, which is kind of scary. Second thing is, do you actually understand why that change occurred, right? Is it a expected outcome? Was it unexpected? But that all starts with knowing, well, what are you aiming at in the first place? What do you think's going on? What do you think's going to happen when you do intervene? What do you think's going to happen if the intervention doesn't work? Like, what are the next steps? And it's not like you have a crystal ball. I mean, we're dealing with humans. We're all fallible. You have good days and bad days. But the thing is, you do not want to go into practice and all of a sudden it's 20 years later and you're like, I mean, I ask this question myself every once in a while. You're like, holy shit, I don't really know if I understand why that happened. Right? Even if it's a positive outcome, you'd be like, I don't know if I could succinctly explain to somebody if we were going to set up an RCT of like, hey, can we do it this way? So I expect this outcome, and then you're going to kind of, A/B it for me. You just won't know. And those are hopefully more often positive than negative. But let's say you're getting a bunch of negative results at some time, like you're going to go fill a lull, and you are facing a bunch of maybe a certain issue or pathology or diagnosis that you're just not awesome at treating, right? It's just a pain in the ass. Like lateral epicondylitis tends to be terrible, or wrist issues, something that's just like kind of tough, hit or miss. Like I'm just not doing awesome with this thing. If you have no system to apply it through, you're not aiming at anything in particular than what you've been taught. Like you're just lost. And that's not what you want to feel 1 year into practice, let alone 10 years in practice, and for sure not 20. So that's why I wanted to do this, because I'm coming up on 10 years in practice, which seems crazy. But if I had to, say what maybe has gotten me, and I'm not trying to toot my own horn like I'm better than anybody or anything, but like that maybe gives me some stage to stand on, that's like, well, maybe I do have something to teach. It would be that I actually think I'm pretty good at like taking a lot of info, sussing all that out, seeing what's maybe one of the most important jump off points, and then intervening. And I think the intervention can be literally dealer's choice with a lot of these things, as long as you know what you're doing. And in R2P land, we kind of are always saying, we're bridging the gap. It's like, you cannot take somebody from injury to performance. You can't. And I know this has become a popular thing, right? That I just, read he's a mentor of mine, read another post by Craig Levinson right before I hopped on here, about the WHO guidelines and this, epidemic of, sedentaryism that's leading to chronic pain issues. There is, and you're going to see later in the talk, I'm going to kind of decipher that a little bit, but we need to make sure that, like, well, is this a general movement issue, a general unhealth issue, or is this an actual pathology diagnosis, something that you're treating? Those are two very different things. And in my opinion, if you aim general exercise at an injury pathology, something that requires diagnostic criteria, you're not being a physician. You might as well just call yourself a coach. Now, if you want to bridge the gap, you need to be able to have the skills, and then have the ability to take off the physician hat, put on the coach's hat, and then kind of start to bridge that gap, or have people around you that you can hand people off to, but you still have to understand what's going on. So we got to be able to identify what are we actually working on before we just kind of apply general methodology, general movement principles. And if anybody would be guilty of that, it would be me, because I literally wrote a book that's talking about like the movement epidemic, right? Like that we need more people moving, we need more people healthy for sure. But I would assume we would all agree, I would hope, if you had somebody walk into your office with an acute ankle sprain, are you just going to be like, let's just like start deadlifting, right? And we'll just capacitize you. And you just like, you're like, don't worry about the ankle, just get moving. No, you'd be like, you got an ankle issue, like, let's work on the ankle. If somebody, comes into your office and they have 10 complaints and they're, mildly obese and they're on 3 medications, I agree that's a different patient, right? And they are not coming in with an acute issue. If you haven't read the Checklist Manifesto, you absolutely have to, right? We have a reading list at the farm, like you have to. It's just a lot of good stories in there. First of all, that show gaps in medicine, right? It's aimed at, orthopedic physicians, oncologists, all types of physicians. But when we're dealing with something so complex of the human, and then, for us, pain and movement and pathology around the musculoskeletal and neurologic system within a human, it is super complex. So you kind of, there's 2 ways to approach it, really, right? You become the generalist that just does the easiest stuff, right? Or low-hanging fruit. You adjust everybody, apply the same treatment or general movement principles across the swath of your population base. Or you turn into this nocebic practitioner that gets too lost in the minutia, gets too complex. You don't actually get results. You're just tied up in your own, kind of conflations. And again, you don't know, did you make heads or tails, because it's just the complexity is like out of control. So at some point you have to, and I'm going to steal this from Corey, who stole it from Craig, and Craig stole it from somebody else, that like you have to be systematic rather than have systems. I would say you need to have, and we're going to say this later, like you have to have the ingredients of what makes a good clinician from the assessment standpoint. You have to have some sort of recipe or a system or guidelines, whatever you want to call that. I don't care. Sometimes it like makes you want to gag when we hear like protocol or system. You have to have it in the beginning because you have to be able to break it. But again, the book Checklist Manifesto literally showed you could reduce in certain scenarios just the rate of infection by up to almost 90% by just literally having a simple checklist, which seems insane. This is established medicine. We're not talking like early 1900s. We're talking like 1970, 1980s, 1990s. is when they started applying these checklists and saw these massive changes in complications or risk factors being removed. So like I said, you want to kind of make sure you're aiming at the correct population, because we can't go in depth today about, diagnosis and what we're doing. I want to give you the broad, but just, I want you to take this away from the talk today, that just like our top tier SFMA, you're trying to get 4 categorical things there, right? A dysfunctional painful, dysfunctional non-painful, functional painful, functional non-painful. And we're all aiming for maybe that gold standard, check everybody off on that. Functional non-painful, see you later, fantastic. I think we need to approach it in much the same way with just the general patient in front of us, right? That we're looking at, is this an unhealthy person in pain, a healthy person in pain, unhealthy pain-free, healthy pain-free? Because you're going to treat all those people quite differently. So let's just give the top and the bottom. So let's say an unhealthy in pain, and we'll go back. I'll give a specific here, without naming names. I had a patient that was referred into me from a pretty rural area from a primary care practitioner that was dealing with bilateral shoulder pathology, which is for all of us as clinicians are like probably not shoulder stuff. Comes in, I wouldn't even say obese, mildly overweight, lifestyle, when you take her history, not healthy in the least, literally does not drink water, lives on sweet tea and soda. I get there's water in there, but no water standalone. 3 kids, stressed out of her mind, trying to work, make ends meet. I go through a full physical exam and I get done. And I think there is obviously a cervical component here. We go through her shoulder, like nothing's actually wrong, quote unquote, with her shoulders. And I said, there are some things that we could for sure work on, to help alleviate this, and we're going to send you home with some stuff, but I highly encourage you to go back, because this was, again, referred from a primary care physician, to go back to your primary care physician and have a greater conversation about blood sugar regulation, changing your diet, and maybe start to move a little bit, which this patient did not want to hear at all. And then I furthered that explanation with, the only way I think we're going to get you out of pain long-term, not talking today, not talking chiro PT, see if for 4 or 5 visits, which we can have immense change in pain response. But if we're going to keep you out of pain and actually send you down the path of being healthy, which is what we're all trying to do with somebody, it doesn't start with, McKenzie retractions and getting you out of bilateral shoulder pain. It starts with blood sugar regulation. And I was like, I will help you with that. Your primary can help you with that, whatever you need to do. That patient didn't come back until they came back about 8 months later, and they had no shoulder pain. They did no treatment. And what do? Change their diet up, started drinking a little bit of water, took some of the Coke out of their, not Coke like drugs, but like Coca-Cola out of their diet. And came back and literally just thanked me, and had another issue going on, right? Like a knee issue. And it was like, I'm glad that somebody actually had the candor to just tell me what I should have worked on. Because here's, in my opinion, in that case, a lot of people would say, well, why wouldn't you help them get out of pain? Because if you get them out of pain, it might catalyze them moving more. They move more, they're going to start getting more healthy. Or it could have the reverse effect. They get out of pain, 4 or 5 visits, she doesn't come back, even though maybe I've explained that there's a continuation of bridging that gap. And what happens? Lifestyle remains, and now it comes back in, who knows, a month, because the inflammatory cascades out of control. And now it's not just her shoulders, it is her knee. And now I think I have wasted her time by not attacking the biggest issue. And how did I find the biggest issue? Being a physician, going through a proper assessment, a history, and making sure, first of all, what was going on. No major red flags. So I'm not missing something that's supposed to be triaged out, referred out, surgically oriented. And I just feel like we kind of miss that sometimes, because if we're gonna cast a net over if we're, talking the American populace of who we're going to treat, what's it look like? Unhealthy in pain. I'm not saying that we're sending everybody back to their primary care with dietary modification, but if you're not talking about this stuff and you're not assessing this stuff and it's not part of your history and you're not looking for it, I'm just going to say it, you might as well be a personal trainer. that can adjust on the side. Like, you're not being a physician. So take all the health things into account. Now let's turn that on its head. Let's say we have somebody that comes to you that's healthy, pain-free. In my opinion, for all of us, what could that look like? That may look like an elite athlete, right? They may have little, niggles and little aches and, things like that. But let's say they have no major complaint. They're coming to you literally for performance care. And this is called rehab to performance, right? Are you going to aim general movement guidelines and exercise selection at that person? Good luck. Because if they're trying to bump up 1%, or, well, here's a funny little side story. I just got contacted by an Olympic race walker. I've never worked with an Olympic race walker. Like Sloan, actually, my wife has. But he self-admittedly is like, I have to improve centimeters on my stride length to become competitive with other people across the world for the upcoming Olympics. I mean, I'm not making fun of anybody. I was like, holy cow, that's cool. Not my sport of choice. But if I'm making a centimeter change in this guy's stride that then adds up over the strides of a marathon or a 50K length race walking event, do you think you're going to get that from general stuff? No. How do you get there? Assessment. You need the best assessment in the world to make that kind of small percentile change in an elite athlete or even a really good high school or collegiate athlete. Sometimes you have to really be on it. And the Pareto principle, that 80-20 breakdown in our practices, right? You're going to get a lot of people better just by doing general stuff. And that's kind of why, if I'm being honest, a lot of so-so practitioners do okay, because you can do okay stuff and get people better and they go about their business. We're trying to be above the cuff, right? We want to be the best that we can, whatever that looks like. We are trying to help the people that are in front of us to the best of our ability. And in my opinion, and I would hope that if you go to this course or even listening to this day, I can even guide you down that pathway a little bit, that I literally think you can have mediocre treatment skills as long as you have world-class assessment skills and have world-class results. That's the sell point for this thing. I've just seen it too often, right? A decent adjuster, somebody that has a little bit of soft tissue skills, and they are just absolutely crushing it. But every other part, right? Their rapport, the history, how they exam, ruling out red flags, knowing what they're treating if you talk to them, able to communicate it to another practitioner or another or the patient. All those things are so good. And then if you or I got treated by that person, we'd be like, I'm going over to this other person, because you're they're better hands-on or whatever. But I just, that stuff is absolutely important. And I mean, I work on those a lot, but I just think we're starting sometimes in the wrong spot. And then it's hard to integrate all these techniques and methodologies and hands-on skills. So it's get a good basis in what we need to know, right? Hands-on skills, adjusting soft tissue, have a couple techniques that fall outside of the norm, and then start applying those within a model where you actually know what you're aiming at with those things. If you can do that, that's where you're going to learn if you're good or not, and then also be able to review and reprocess when you don't have a great result, or when you do have a good result, what do you actually think happened, right? Never kind of resting on your laurels of well, let's examine the good ones too. And that kind of brings me to here, your whole assessment system is just kind of a cross-examination process for yourself, good or bad, good outcome, bad outcome. Why didn't that person come back, right? Communication skills. But that's part of your assessment, which is also part of this course, right? That it's, I want to walk you down the path of what do world-class diagnosticians do, and what's the ecosystem of practices that they surround themselves with to get better every day. But also, how are they assessing their own day-by-day improvement, or their own skills, or their own outcomes? That's a separate thing in itself, because if you don't take time to slow down, review, have feedback about yourself, whether that's from patients or people around you or something you can do on your own, you can literally think you're the best in the world. And if you went out and somehow could pull all your patients over the past 6 months, I think a lot of us would have like literal like nervous breakdowns if you pulled your patients for the past 6 months and just said, rate me 0 to 10 on like, communication, how good your outcomes are at 6 months post, would you come see me again? Like I just think we would be like, oh my God. And the reason I'm saying this, so Sloan and I did this 2 years into practice. We put out a Survey Monkey with like 10 questions. And one of the things that hurt my feelings the most was the music selection that people kept hating on for The Office, but that's a side note. But yeah, we did this to ourselves, and it's, you don't want to read this stuff, right? Because we had a other category at the bottom and people could write whatever they wanted. They were all anonymous, and we literally played the game for probably 3 months afterwards of all the negative anonymous ones of who was that? What case was that? Because you like hook on these things. So you do not want to have to rely on a Survey Monkey to get your feelings hurt. You need to have some sort of feedback loop within, visit to visit, day to day, week to week, month to month. And that's part of this class or this seminar is, well, how do you keep getting better over time, right? What's that path look like? So, like I said, coming to a seminar like this, like I fully expect you to see what a world-class assessment diagnostic process looks like, not just my own, and not just within our field, and not just within medicine, right? I don't think we had a contractor come to our house one day to just weigh in on a project. And literally he started just looking around, not like, oh my God, this is wrong. He's just like, well, have you guys ever like, talked to anybody about this? Like, have you ever thought about that? Like literally just going through the house. By the time he's done, I literally had like a legal pad filled with stuff that he helped. He was like, hey, you can do this, you can do that. He was a diagnostician, right? He's like, I have been in this game for so long that it's just easy for me to say like, these are things you need to work on. These are things you could work on. These are things that would be nice to work on. That's kind of what we want to know. So I kind of like that, where you pull in other fields here, just like, what are the best do that are looking at assessment and examination processes? Like I said earlier, what are the ingredients, the recipe, and how to make it your own? That to me is what's the ingredients recipe of the system. You have to have some sort of a system. You got to build it. You can build it on your own. Why? There are other people that have put a lot of this stuff together. I don't think anything is holistic or stands on its own 2 legs. But that's what I'm going to kind of go through. And then it's like, well, how do you actually, we all hear these fun terms of like clinical jazz and creative expressionism within practice. That's great. But like, how do you actually do that? Instead of just like flying off at one point and be like, I do it this way. I do it like, why? Like there's a process to that. And I bet if I can watch the, I don't know when it comes out, the new Owen Wilson movie where he basically is like Bob Ross, but it's not Bob Ross. I bet I'll pull a lot of stuff from that too. So just get ready. And a principled approach to your work. Literally Craig Liebenson's company is called First Principles of Movement, right? We talk about first principles. Principles get talked about. It's not like, when we go through this, I want you to be, to realize that we're all operating from the same principles. It's not the principles of R2P or the principles of Bow or Art of Assessment. It is literally the principles of modern medicine and then the specificity within conservative musculoskeletal care. There are principles that stand on their own that I think if you do not adhere to those, it doesn't matter what else you're doing. Like you're already kind of like lost. So we want to kind of set those in stone. And then, like I said, this is a really big deal to me. That if you're not getting better every day in your practice and you don't have something to shoot for, right? I made this statement on a podcast one time that I want to be the best clinician in the world. I got ripped to shreds afterwards. People just like, oh, you think you're going to be the best? Like, if like the best that I can be is the best in the world to me. And literally people are like, oh, those people, whoever commented negatively, already knows inherently they can't be the best. That's why they're like throwing up this front, right? Why are you even doing this if you're not trying to be the best? Like if you come to a seminar or you're doing something in your life, whether it's a job or raising kids or something, and you're like not trying to be the best that you could be, Like, I think you should just stop right there. Now, if you got kids, you're in trouble. But what I mean is, why the hell are you doing it? Like, I just feel like anything you do, if you went in, you knowing that you're going to stop at half-ass, you're just like, shit's getting tough. Like, it's, I got a lot of stuff to do. I'm not saying it's easy all the time, and it's going to be, you're going to see, let's say, a practice flow. You're going to see times of traction and fast acceleration within your practice. You just feel like, man, getting really good, awesome results. You're going to see periods of stagnation, right? That's normal. But do you see overall, just like a patient, what do you want to see overall? Progress, right? It's not the visit to visit, just linear. It's the fact that, like, you still see, okay, man, we tracked over this period of time. We're still moving upward. We're not flattening. We're not plateauing. A big deal to me. And I really think that that's worked well into this class of just being a good clinician overall, but obviously the path to mastery of being a good diagnostician, which, in a funny way, being a good diagnostician, if you've listened to any of like Rick Rubin's podcasts or talks about his new book, it's literally just about like being a more present person within the life that you're living, right? Paying more attention more often leads to better creative output, better conversations, in this case, better clinical outcomes. So you're going to see a lot of this goes outside the scope of what we do as professionals. And if you become a better assessor, diagnostician, can pay more attention, be more in the moment all the time, of course, you're going to have better outcomes within the exam room or treatment room. The famous slide, if you haven't seen it before, I apologize, but there it is. At this point, open to any questions about the class. If anything's like super specific about like, what I'm teaching, like, I'm just going to wait, because that's the whole reason for the class. I don't want to spend like an hour on any one topic. But if you're like, hey, are we going to be doing this or that, let me know. Or if there's anything else, just ask away if there's questions here. And I'll stop sharing this too. And whoever Sharon Lamb is, fantastic picture. So. I can't hear Kat, by the way. I don't know what she's saying. I don't know if I need to.
Can you hear me now?
Yeah.
Okay, sorry, I was speaking to everyone in here, seeing if they had any questions. But I have some questions.
Yeah.
So we get a lot of people who are like in lower terms. So why do you think it would be important for them to attend something like your course?
Yeah. I don't think this is going to be heavy in anything. Well, it's not going to be. It's not a technique. It's not a method. So I don't see it as adding anything. If anything, I think it's going to help you kind of put your ducks in a row, because a hard thing, and you all know this, if you're in the midst of school, whether it's PT school, chiro school, whatever it is, it's very hard to start to like see the forest through the trees, right? Because you're in school and you go through, just like we all did, right? Basic sciences, and you get into like foundational clinical work, and then it's clinicals themselves. But that's all biased by the instructors in front of you, as bad as that is to say, right? So literally somebody could have a little bit more bias teaching you whatever it is. It's crazy. It sounds like diagnostic imaging, right? Or some technique. And now you're getting their perspective of it. And then you pick that up, and pretty soon you're like, man, I never even thought about something like that. I think the way that we look, and like I said, I think this is probably the biggest flaw in our profession, is that we can't even agree on what we're working on when we're seeing a patient. So if they've done these studies, right? We take 20 clinicians and we literally put the chief complaint and the patient in front of them. I bet we're going to get 20 wildly different treatments. Now, I said earlier, you can aim a lot of different interventions at, a chief complaint or an injury or pathology and get fantastic outcomes. But I don't even think we would agree on what we're aiming at. So that's where it gets like very confusing for students and even clinicians. If it's like, wait a minute, Bo's over here saying he's treating, an intra-articular hip issue, and Kat's over here treating lumbar radiculopathy, and Seth's over here, putting vials on people's chest and muscle testing. And it's like, what are we aiming at? And then we see all three of us go in and adjust lumbosacral junction and do a 3-month supine and then do some hinging. We all do that. And then they're like, what the hell's going on? And we all have outcomes that are somewhat positive. You can see very easily this can get confusing. So I think, and I'm not saying I'm right when we get to the end of an assessment, but I think if you go through the process, what we would see is more often than not, you'd start lining up like, oh my gosh, we are aimed at the same thing. I think if you put the best clinicians, all the people that we love, right? The Brett Winchesters and Pavel Kolaj, and you put all these people in the same room as a clinician, and they did these, right? Stu McGill and Kolaj, they've done this, right? They put a person on stage, they have one person go up and treat them, and then they take them off, put the other person up, the same. Because when you're good, you're following whether it was laid out by them or they just fell into it because they're, the proclivity, their talent, if you want to say, led them that way. But like, there's a reason and they're the best in the world. And I think it's because they can get to a pretty clean diagnostic place to begin with. That's a really good question. So let me, Seth said I hit the nail on the head for his style, which of course. And again, now Seth has assessment and treatment built into applied kinesiology because all he has to do is give him some vials, adjust them, it's going to change. And he's like, dude, look at that. Now, I'm not knocking AK, but I am. What else we got? And I'm trying to think of common questions I've had too as we're going through this.
I got something, Bo. Seb.
Yeah.
You hear me okay?
Yeah.
Before any of the students come to a workshop like yours, is there anything that you feel like they should read or look at to maybe get better an idea of how to apply the things you're talking about maybe at the workshop?
Yeah, that's a really good question, Seb. There's nothing that's like profession specific, right? Like this chiropractic text or a clinical text, like we're all gonna, be surrounded by the same stuff. I'm gonna pull from a lot of those texts, like Annie O'Connor's work, and like I said, like a thought process, like the Checklist Manifesto. I don't know if there's any specific work. The one thing that I would say, let's say you've gone to like an SFMA seminar. I think that's going to help you a lot just because of how systematic Greg Rose is in approaching, looking at movement. And we're going to use some of that both within the assessment and then kind of comparative analysis between maybe what that's, leaving out and where we could, go further and what we take away from that kind of a process. And that's what I want people to understand here. I'm going to give you a pretty strong like framework, but I'm not saying this is how it's done because that can't happen, right? So let's say I have a practice that is very, let's say it's oriented to kids. Like I see most of my patients are under 10 years old. I would hope most people would agree if I went toe to toe with a practitioner that's seeing most people that are over 60. Now we could say, yeah, they're humans and they do the same stuff. Like stuff needs to look a lot different for a lot of reasons. Right? Expectations, growth spurts, what they can do movement wise, what we're actually focused on, right? Balance fall prevention versus developmental proficiency before we start loading strategies. Like those are built into your assessment. So you can make things super specific, but it all gets put through the filter of applied science. And to Seb's question, I guess the best answer is, by the time, at least the school I went to, by the time you were done with 4th trimester, you are through the core sciences. If you are through the core sciences, you have everything you need to be able to filter information as well as anybody out in our profession, because everything else is built on that. And that's the reason you go do that stuff first. And I will harp on that so much at this seminar that you will get tired of me, calling out and emphasizing and highlighting, hey, when you're doing this, what do you think's happening? Explain it to me mechanistically, right? When we're looking at this, what's going on? Because you need to be able to explain it to yourself in terms of physician, so that it's easier to explain it to a patient or a colleague or a different professional, a coach, a trainer, whatever that might be. I'd say, there's no suggested reading other than basic sciences. So I'd say, yeah, if you're a try one, is it going to be tough? Yes. If you're beyond, like for us, again, I know this is different with quarters and everything like that, but try 4, like it's game on, man. Like start building your diagnostic system and criteria from that point. So I mean, what you're going to be seeing patients in clinic less than, 3-4 tries later. They give you a process, in our case in student clinic and then outpatient, where they're going to have a checklist, right? You're going to have regional exams and like this review of systems. Like, is that good? Yeah, it gives you something to work off of. Is it great? No, right? Subpar assessment's going to get subpar results, right? It doesn't matter what the intervention is, in my opinion. You get lucky sometimes, for sure. So start building those chops early. Good question though. Anything else? Again, this is your guys' time. I'm open for whatever.
I have another one then.
Yeah.
No one hasn't. So I know you mentioned something about like being the best clinician in the world. I guess I feel like a lot of us, especially when we're in this like R2P world, right? We have imposter syndrome because we're like, oh my God, I don't know enough. So what do you think are some of the best ways to kind of like fight that? Or are we ever gonna fight that? Or I guess how do you kind of go about feeling that way?
Yeah. It's a great question because, I think that the imposter syndrome, right, it gets labeled. I think I'll pull this slide up in the talk, and maybe you've seen it before, Kat, where I go through this like competent confusion phases where like you're trying to realize like at some point that, let's say we're talking about the best in the world again, they realize that nobody really has a great amount of foundational information for what we're doing other than the basic sciences. Is everybody with me on that? So let's say you're a big DNS head or you're a big neurodynamics person or MDT, realize that those are methods, whether they've been rigorously tested or not, that are built upon applied science, anecdotal information, patient visits, time, but those are still theories, right? Nothing's a law from any technique. I mean, we have very few laws within physical medicine, and those are applied physiology laws, right? Like Wolff's Law and all these things. So what we got to realize is like you're an imposter forever. But that's what keeps you doing what? Always going back and checking your work and trying to make yourself better. So I actually think like I 100% like there will be days I go in, you get done at the end of the day and you're like, Jesus, I am terrible. Like literally you're just like, you need those days, right? And it's not like you were off your game. You may have just got smacked in the face with a bunch of like, I don't know if I'm on it. It's not the result that I thought was going to happen. You had a bad, like maybe just personality, like friction, what, like all these things, and maybe get like 5 of those in a day, and you're like, oh, God, I quit. But that's where you're going to be like, am I actually any good? Right? Or you'll read something or see somebody else doing something. You're like, wait a minute, are they getting those crazy results doing this thing that maybe conflicts completely with my ideology? You got to have an open mind. You got to be willing to change based on new information, new ideas. But I kind of like all that stuff at the end of the day, and I think it's a good driver. But I think if you asked anybody, do they have imposter syndrome, they would say yes. And if they say no, they've already stopped learning. They're as good as they're going to be. And to be honest with you, anybody that says like they don't feel like an imposter and they're completely like comfortable in their skin as a clinician, I don't think you're going to see a lot of people refer to them from higher level people, because like that's going to get like fed into the patient visit. Like, oh, we know what we're doing. You want confidence. You don't want cockiness, right? You don't want to be overconfident. That's just, it gets people in trouble. It's a little bit dangerous. It's a great question, right? But yeah, we'll literally talk about like what I think is the process of like what you travel through from like before you go to school, phases of school, getting out in the clinical world, and like where we land, years into practice, and then you're always in that realm and you're just kind of like bouncing a little bit up and down, right? It's like ohm track and a core 360, right? You get somebody to like increase intra-abdominal pressure, and then it's like from there it's incremental, but you're like, yeah, it's gonna go up. You're gonna deadlift heavy. If we're walking, it's a little bit less, but like it's still better than it was before you knew how to do this at all. It's a great chiropractic analogy right there. Hope I got some silent claps.
Hey, I got one, Bo.
Yeah.
Hey, of your classmates, at least the ones that you're familiar with still, how many of them do you feel like actually continue to learn things after they actually graduate and have their practice going? Yeah. How many of them actually continue to change?
Yeah, that's a really good question, because I'm just trying to like think, we kind of probably all stay in touch or keep tabs on social media, and then the ones that I do still talk to. It's a level that I think we all would think is good, if I'm being honest, if we're like, and that maybe doesn't mean seminar junkie, but still pushing a handful. And I started with 127 and graduated with our core group, our class, like 28, 75 people total, but that was matriculating in and out, right, between tries. But graduating with those, 70, 80 kids or students, a couple. I've kind of, I've seen a couple cool ones, like a guy that was was a second career, very traditional in school. What he thought was a black shirt, which for anybody who doesn't know, it's like this weird fraternity where you just adjust people, and I don't know, I think they cast spells or something. But then he literally called me like 3 years into practice, and he was like, I'm doing a disservice to patients, right? And he's like, and he literally just started going crazy with this stuff, and he's in Jersey, and like his practice just like took off. And like, I'm not saying our practice, it's like you have to practice like us, but I think there's a big difference too of getting stuck within a ideology that also has a ceiling. Just even if you went to seminar after seminar, it's just the same thing, right? You're not actually growing because you're captured within the bubble of ideas. So I think you're trying to kind of always pop your bubble of ideas and be like, I'm going to go a little out on the fringe, and also have the ability to come back and make sure like you don't get too far out there ever, which is all why you need to surround yourself with like responsible, competent, intelligent people, right? So you can have people that can sometimes be like, whoa, that's cool, but can you explain that to me as a scientist would, before you just say, hey, we're going to start doing this, crazy technique or whatever. Yeah, I'd say it's a small handful. I don't know if you'd agree with me on that or not, Seb, but maybe that's different now, because also a lot of the stuff that I currently do, and I know that you do, didn't really exist. So maybe hopefully that would be the mission of R2P, right? That we're growing that clinician, right? Not pool of clinicians, but for the most part, I think people get busy, they get a family, they start making decent money and kind of stagnate, and they go to their state association meeting and get their CEUs and rock and roll. They're probably getting better technically, hands-on skills, but if I had to challenge them, if there's a assessment showdown, if we're going to draw pistols and go for it, I don't know if too many would be awesome at that. So that's a very good question, and I think that's what we're trying to do, right, is put really good coursework out there. And I'm not, mine or R2P or whatever, like we just want really good stuff so people don't have to just like do whatever their state approves. Like that kind of drives me crazy. So if I can help that in any way, that's why I'm doing these classes. Oh, good question.
Yeah, I would agree with you though. With I know with my class, I think we had about 90 people. There was, I think a lot of them are just complacent, from what I've seen. But at least I see with this new group, like there are a lot more awareness of other methodology out there, and ones that have come around. So I think the R2P group is doing a good job of making some awareness of that, because it would take probably at least I graduated in 08. It's a hard time to find all those things, especially when you do have money coming in and you have kids and you just get busy.
Yeah. What gets harder, it's just like anything, right? When you start making money and getting, let's say, just results or making money, it's really hard to be like, I'm going to check myself, make myself do something different. And it's even harder to go to a seminar that may be completely, out of your wheelhouse, and then also apply those things, which somebody asked that question on the last R2P residency of like, it's great to learn this stuff. How do you actually apply it? Like you literally have to make yourself uncomfortable. It may make you a little clunky. It may take more time. Like if you don't do that stuff, actually, our other doctor, the other day, he asked a really good question. He goes, I know when you first got into practice, you made yourself like do stuff, right? If you learn the SFMA, you put everybody through the full thing, right? If you started doing more vestibular vision work, you just, did all that. He goes, now that you've done a lot of this stuff, like, do you still find yourself doing that? And I was like, man, I hadn't thought about it. When I thought about it, I was like, I actually think I'm constantly trying to like challenge myself within each patient visit or each patient case. And this is going to sound a little on the fringe of like, why would you do that? Right. So I may know that I can get a patient where I want them with a certain, like, you know, kind of like, man, if I went through this treatment, I think this is going on, this is where I could get them in 6-8 visits. I may throw something in there that isn't going to be negative, right? So we call that kind of a benign intervention. It's not going to have any negative, but it could have a positive, but I also could learn something. And I hope everybody's with me on that. So it may seem like fluff. It may take more time. I may actually need another visit, and I'll explain this to a patient sometimes, like, hey, I'm going to do this. I fully, you know, want us to get here. If this doesn't pan out like it won't, we can just like switch gears next visit. And I know it's going to happen with this. That's tough to do, especially when you're new, because you're going to be like, I want them to love me. They want to, you know, want them to send you a Christmas card, hug your kids because you're just the best person in the world and you're trying to get paid. And you're going to be like, nope, I'm going to just stick to let's just do some press ups and a dead bug and see ya. It's like, yeah, you can get a lot of results with a lot of very fundamental stuff, but like, you got to push yourself a little bit. That's tough. And somebody that's really good at that is like a huge mentor of mine, like Brett Winchester. The dude learned something. He's really intelligent, so he can integrate it, be quick about how he processes it, but plug it in for a while. And then he's also good at calling his own bullshit and being like, that didn't really work. Oh, that did work. Why did it work? Let's look at it. Like, I mean, that's what we need more of, is like literally the scientific process within your own treatment room. And it's not easy. It's very, I am envious of some of my good friends that are chiros that adjust people, do soft tissue and send them out. You know, they do rehab with somebody else. They're all these ancillary services. That is it super appealing at times, because you're just like, man, could make a bunch of money. I wouldn't have to think that much and I'd just be doing it. But at the end of the day, I probably wouldn't be in practice in another couple of years if that's all I was doing. So not because I'd be retired with a bunch of money, I get bored. Yeah, and it's not. I bring Winchester up all the time. It's just because he was in my purview. I want everybody to understand that. It's not like I'm like, ooh, he's the best. Like, I worked for the guy as an intern for 2 tries. I was going to work with him. I've worked with him after practice. Like, I've just kind of seen also the evolution of him. So I've seen somebody that started out that was really good from the get-go, but it keeps getting better. Like, that's kind of like a pro athlete and trying to get incremental gains. He is, because he has a good process. So like, there are people in our profession that I think we need to be listening to more than others. And like, that is one of them. And there's a reason that he is speaking all over the world and gets really good results. Like, that's what we need to strive for. So you need to have some sort of like, you know, a gauge or a mentor where you're like, yeah, I can look up to that person, and it's for a good reason, not just that they make a bunch of money or they're, you know, famous on social media, whatever it is. Yeah, sorry, what was your question?
Hey, yeah, my name's Garrett. I'm a first term in clinic, so term 9 here at SU. I kind of wanted to just ask about general patient communication. And I noticed, like you mentioned previously, the unhealthy in-pain patient you were dealing with that was like had high blood pressure, and kind of like what that communication looked like. Like, she's coming in for neck pain or bilateral shoulder pain, cervical. And, you know, you kind of just addressed the elephant in the room as opposed to that. It's got to be a hard conversation. So
hard conversation. This is really a good question, because this will help like kind of pull back the curtain on what this whole class is like. So it's much easier to answer your question and be like, this is how you communicate to patients that are unhealthy in pain, versus being like, I mean, this is Annie O'Connor in a nutshell, right? We're going to personality classify somebody. We're going to pain classify somebody. We're going to see how those two are playing together. And then we're going to do what? Take into account my personality and how it interacts with their personality. And you're literally doing this, and you won't even realize it eventually, right? Because you can't be aware of this stuff. You don't even realize you're calculating all this stuff. Who are people that are really good at that stuff? Natural salespeople, right? CEOs, all these people that they didn't have to sit down and write out this process. Some people do, and some people have to practice it, right? That's why you can teach somebody to be a salesperson pretty effectively. I think we all know that by now. But that's what a salesperson is doing, right? building rapport, understanding the person in front of them, understanding how they interact with them, understanding their problem, and then can they solve it or not? That's all we're doing. And I'm not saying we're salespeople, but like your communication is different with every person. That's that whole N of one. But there are principles behind how personalities and how people work and how to diffuse situations, how to, get buy-in. That's what we're all wanting to know is like, well, how do you manage people? That is the toughest part of practice, in my opinion. The management of personality and people and getting buy-in, motivation, building rapport. Because if you can get time from somebody, right, like those 6 to 8 visits that if you get, you're going to just have, stellar results. You get that, and you get that in a positive fashion, not a contractual one, right? Pay me up front and I'm going to make you come. Maybe there's positives to that too. I just think like your results start going through the roof, right? Because like you built this whole like little micro environment of success already. So yeah, we will 100% address like what the best in the world. That's why I said like that's not a clinical thing. I do not think if we took medicine and said it's the best communicators in the world, hell no. No. The people at the top in particular in like our field, because we're so hands-on with the person for a long time, like we become really good communicators. But the best communicators in the world are up on stages talking, right? They're teaching. They're, like I said, those CEOs, they're salespeople. That's who you need to learn from, right? And then be like, oh, I need to apply those things in my exam room. Just like I said, you can learn from a contractor as much as you can learn from a school teacher, a track coach, a veterinarian. Like we need to be way more open-minded about what we're doing in our exam room versus just like, what other clinicians are teaching us, because that's still a bubble and we want to pop that one too. Anything else? I don't know how long we're on here, if it's an hour or shy, but I'm here as long as you
Yeah,
guys.
I've
We
got
probably have
one thing.
about- Oh, sorry.
You're good.
Yeah.
Go for it. No, I was just saying
Uh,
we probably have about 5 minutes. So
Okay. So we want
this
more.
this I don't know if it's necessarily a question. I think it's more just directed at the group, even though it's not my talk. For anybody who hasn't obviously heard Bo talk, but that slide that he has in there about the unhealthy, pain-free and stuff, like that's gold. Like if y'all haven't seen that before, like I think that's probably one of the most crucial pieces. Especially like I'm kind of like second try in clinic. So it's like you've never really had to have these conversations so much of maybe like what happens whenever you go through your assessment, like someone comes in with pain and it's like everything works good. And it's kind of like the Finding Nemo story of like they're all in the plastic bags and it's like, now what? That's kind of how it feels. And like I recently just had that happen to me in clinic. Like someone who's pretty overweight says she has like degeneration in her knee and like that's what she's sold on. But throughout her history and stuff like that, she tells you that like anything that's like inflammatory that she takes out of her diet, things get a whole lot better. So it's like having that communication with the patient. And it's like it's not a fun talk to have necessarily. No one wakes up every day and is like, I can't wait to tell somebody that it's probably because of like their health that they are in pain, right? Because they're seeking you out. But if you just if you want to hear him talk, and like I think that's probably the best thing that you could hear him say, at least just out of the entire seminar that he has. If you hear just that segment and can apply that, once you have like whatever system you want to use to find your assessment and you run through each patient, that comes back fine. Like you're now what question? That's probably the toughest thing, but the best thing he could have said. And I've asked him all the time, like for that question, and he gives me, I'll say it. So he's my mentor and I will say it. He gives me vague answers every once in a while and I want to kick his teeth in. On purpose, but it has helped me because when I get to clinic, it's like I get my teeth kicked in and I'm like, I'm glad that he did that to me, because now it taught me how to go and like think for myself outside of that to have that conversation. So that's all I've got to say.
At the end of this, there'll be this is non-paid promotion, the little legal talk underneath Seth's name. But
yeah, I would talk about it more if I was getting paid. I would talk about it way more.
But what I want to get you guys excited about is I don't know, maybe I'll find the stat before I bring the class to Costa Mesa. like in Alabama, we're a primary portal of entry. You're pretty damn, we're not primary care physicians. That's not what I'm trying to make us. But I'll tell you what, there are a lot of people running around without primary care physicians. There's a lot of people that are going to bring stuff to you that should be brought to a primary care physician. There are a lot of people that will not go to a general practitioner, even though you tell them to. And I'm not saying you handle that, but if you don't know how to manage that person and their health as a primary, that's why we are a primary portal. Like, why'd you get into this profession in the first place? Like, I want to be a clinician, not just an adjuster or a soft tissue practitioner. That stuff, yeah, like I like doing it, but like I want to help somebody with their health problems, improve their health, make them the best they can. I'm under the firm belief, maybe there are other people that are like a million times better than me with their hands, but like that is not just going to happen with so-so assessment, good hands-on care, and getting them to, you know, lift some heavy weights. As much as that gets like puffed up of like, that's what we need to do, right? Like load them up, you know, capacitize them, get them moving. That's all great. That's part of it. It's only a part.
All right, go for it.
Hi, how's it going? I'm a
Hey, sorry.
second termer here, but I was just wondering, like, what's a key quality or habit that would kind of lead you towards being the best clinician you can be,
Yeah.
at least for you?
Yeah. I know this gets a bit cliche, but it's the truth, is like curiosity. I think, you know, you could look at it as like I said to Kat earlier, like the imposter syndrome, like you're kind of deflating yourself is why you go back and look at the case or a certain like thing that you're not good at treating or whatever, a skill set you lack. I think it's honestly curiosity. Like you're more like, God, like I'm constantly, Seth knows this from being in the clinic. I'll literally get the result I want and come back and be like, I wonder if I would have done stuff in this order or not done this or done this instead or said something different. Brett Winchester and I have said this numerous times. If you could somehow suck the personality of yourself out of it, if you just had this like blank slate, would you still get the results or not? Like say it was stellar, say it was negative, and like you took away all of the effective stuff, would it still be as good? I am constantly curious about that because why? We're very complex. So the interaction is like tough to like determine like what was the actual like, you know, A plus B equals C. It's almost impossible. As much as we want to say, you know, A plus B equals C, it's impossible. So it's kind of up to interpretation, but I don't think we want the interpretation to get too sloppy. Otherwise you don't know where you stand. So yeah, I'd say curiosity for sure.
For sure. Thank you.
Yeah. I think oh, go ahead.
Yeah, I was just going to ask, because you said you were acting in a role where you want to be a clinician, not just like an adjuster or anything like that. Do you do stuff like the PAR-Q or anything like that to make sure that the patient is the right fit and that it's not somebody that should be somewhere else? Or like what sort of assessment stuff do you have for that?
Yeah, so I think you got to take into account that every time you have a patient encounter, regardless of what's going on or what pathology, complaint, what services you offer, the first two questions you're asking, what can you rule out red flags and should they be in your office, either based on the red flags or based on skill set, what you offer, even personalities, right? Do you actually fit? But I just think that's, again, like I'm going to bring his name up one more time. If you look at Brett Winchester, extremely good and extremely fast at triage. Like I'm talking, if he knows it's surgical, they are not spending a trial of care in his office. It's not 4 visits. And you need to be that good. Some cases you're not going to be like, oh, I know it's surgical right away. But if you pretty sure, like 99% confidence interval, it's a surgical, like say they have a torn labrum and you're like, man, this is just, I know, like get them out of your office, right? Let's say it's a chronic pain case and you know that it goes beyond, or there's nothing, right? You go through a top tier SMA, there's no, reproduction of movement. You go through orthopedic local exams, no reproduction. They're a 76 on a yellow flag score. And you shouldn't be handling them, in my opinion, unless you're Annie O'Connor, right? You need somebody that can help them from a psychological standpoint, a good coach that can start to work them through some of those, fear avoidance things, whatever that looks like. But maybe that's your specialty and that is what you work on, then that's your thing. But yeah, you're again taking all those variables into account, but that literally is the first step of the great assessment process of should you be going further than the initial. And you're not kicking people out of your office, you're just doing what? You're moving them around really fast, but you have to put a network around you, right? People to refer to, people within your office that offer different things than you do. Obviously, that's vital, because that's really tough to do, is to say, hey, I'm not the man, I'm not the woman, I ain't got it all for you. But you also can't send them into the ether of you need this, but where do I go for that? And then you send them to a subpar, they find somebody else, they hear something that's outside of the narrative that you think is appropriate for them. So again, that's part of being a clinician, is managing triage, putting yourself at the center of triage in a lot of these cases. So that's what most people lack nowadays, is like a quarterback, right? Hyper specialized orthopedist, neurologist, rheumatologist, whatever it is, to get all these things spun up, a bunch of medications that come to you, and you're like, dear God, this has been so mismanaged. Like, my job's harder to literally undo the knot, and I'm going to line all this, string up, and then we're going to start reinforcing it really nice. Yeah. Good question though. I think we're out of time. Kat's looking at me with a backpack on.
Appreciate it.
Yeah, absolutely.
Yeah.
Hey, Bo, Nate Cimento here. I'm the faculty advisor for the R2P club here on campus. So I want to thank you for showing up and giving your talk. Great points you're making. Love the content, love the message overall. I think it was really helpful for a lot of the students. So I really appreciate that. You're welcome back anytime you want to, talk on campus. So thank you very much.
Appreciate you being here. Thanks for taking your time.
Yeah. Yeah.